Hi everyone. I'm Scott Podolsky, and I help to co-organize our Department of Global Health and Social Medicine seminar series. And as many of you know, our department, especially through the work of Eric Krakauer, has long been invested in global palliative care, with Dr. Krakauer and several Harvard colleagues, including our late chair, Paul Farmer, having served on the Lancet's 2018 Global Commission documenting the enormous access gap, an abyss, as they termed it, in global palliative care. We're thus proud to initiate an ongoing series on global palliative care as part of our overall departmental seminar series. We're thrilled that Dr. Hadid Tachu Kane, who has worked closely with Dr. Krakauer and was a dedicated clinician and researcher and educator in her own right, along with Dr. Krakauer, will be taking the lead in this palliative care series. A medicine physician at Massachusetts General Hospital Medical School and internal medicine residency at Northwestern University Feinberg School of Medicine, and a palliative care fellowship through the Harvard Interprofessional Palliative Care Fellowship Program. She's a member of the Global Palliative Care Group at MGH and Harvard Medical School, and an affiliated faculty member of our own department. Dr. Krakauer received his MD and PhD degrees from Yale University, trained in internal medicine at Yale New Haven Hospital, and completed fellowships in general internal medicine and medical ethics at HMS. At MGH, where he's practiced medicine and palliative care since 1997, he co-founded one of the first palliative care specialist training programs in the US. Since 2001, he's provided training and technical assistance for
Looks like we have some technical difficulties with Scott.
Patty, why don't you take it away?
Yes, absolutely. Sorry about that. The vagaries of Zoom. Welcome. Good morning, good afternoon, good evening, everyone. Welcome to all of you joining us locally from Boston, Massachusetts, and from around the globe. As Scott mentioned, my name is Hadi Khan. I am an internal medicine and a palliative care physician at Massachusetts General Hospital and on faculty at Harvard Medical School as well. On behalf of the program in global palliative care at Harvard Medical School, and namely Dr. Eric Krakauer, Dr. Hiba Osman, Dr. Sarah Slater, and Dr. Jimeng Jia, I'd like to welcome you to the first installment of our palliative care lecture series. This platform will be dedicated really to discussing topics related to the development of palliative care in low and middle income countries, including education, research, program building, policymaking, and contextualization. Our featured speakers will be world-renowned palliative care practitioners, educators, innovators, researchers who are doing foundational scholarly work in this important field of palliative medicine. Eric will tell you a little bit more about the program, but I wanted to give you just a little bit of an overview. The group program in global palliative care at Harvard Medical School really is Eric Krakauer's brainchild, but with the meeting of the heart and the mind of all our colleagues involved, we were able to set up this program with one vision, that is for the world's most vulnerable to have access to palliative care that prevents and relieves illness-related suffering and promotes well-being. We work with partners in low and middle-income countries, notably currently in Vietnam, Rwanda, Senegal, China, and beyond, to educate primary care and specialist clinicians to practice pain control and palliative care, to produce palliative care leaders and teachers, and to pursue rigorous, locally relevant scholarship related to palliative care. With our regional colleagues, we hope to co-create and participate in a research network on culturally and context-relevant palliative care. For our inaugural lecture today, we are honored beyond honored to welcome Dr. M.R. Rajagopal, who's the chairman of Pallium India. And without further ado, I'll take it over to Eric to introduce our speaker. Thank you for joining us.
Thank you, Khadi. And I don't want to take time away from Dr. Rajagopal. It's really a great honor to have you with us, Dr. Rajagopal, to help us launch the Harvard Medical School Department of Global Health and Social Medicine program in global palliative care. It's a very exciting time for us, and we're so pleased that you could be with us. You know, ideally, medicine is not, in my view, primarily a profession or a métier or a career. I think of it as a calling and as a responsibility. It's an attention to the call of those who suffer and a response to relieve suffering, both through medical care and through accompaniment, in every sense that Paul Farmer meant it with that word. Accompaniment throughout the illness course, or what Dr. Rajagopal has called walking with the weary. And I encourage all of you to attend to his book, recently published, Walking with the Weary. Dr. Raj, or rather in India, he's always addressed as Sir. Dr. Raj, or Sir, exemplifies medicine as a calling, a vocation, and as a medical, moral, and human responsibility. I think this call can become difficult to hear sometimes when one focuses on just one organ or one category of disease or one technical medical skill. But Raj shows us in his work, in his writings, that palliative care, certainly palliative care, is and must remain a response to this call. And I would also add that Dr. Raj insists on continuing to accompany the poorest and most vulnerable patients. And if we listen carefully to him, I think he will accompany us and show us the way. So Raj, welcome, thank you. Please show us the way.
Thank you. Such a Eric, tall order coming from you particularly. But thank you very much. Signal honor to be here as you launch the series. Friends, I think it was in the third edition, a couple of decades back, of the Oxford textbook of palliative medicine. There a chapter was written by Dr. Jan Stenswald, the former chief of cancer and palliative care at the World Health Organization, a human being like none. There cannot be any match for him. He and Sandro Pampelona, a researcher, together wrote this chapter in which they make a statement. No country can stand alone. We are all citizens of one world. We all have a joint future or none. I'll repeat that. We all have a joint future or none. If you think about the developments over the last couple of decades, the world over, the meaning of this would be very obvious. Eric, as soon as I finish talk, I suppose, is going to rush to Rwanda. Is it because Boston, Massachusetts does not have enough work to offer him? Why does he keep flying to Vietnam and Nepal and all over the place? Because he is also affected, I expect, by what the Booker Prize winner Arundhati Roy calls the vulgar disparity of life around us. Today, I want to talk to you a bit about that vulgar disparity of life around us, globally and locally. And then there is no meaning in moaning about problems unless we can think of some solutions. I want to describe to you some of the work that we do in India and use that as a launching pad to describe what I feel we should be doing together. So thank you all for being here, friends. And once more, Khadi, Eric, Scott, thank you for this great honor. I said we'll talk about the motives of medicine. We all in the field. The 119 people who have logged in all have one common calling. We may have come into it for different reasons, but once we are in the field, we realize what a huge privilege it is to be part of healthcare. Because as healthcare providers, we find ourselves in a position of being able to make the most difference to other people's lives. I make that statement deliberately because we see people at the most vulnerable times in their lives. And we have this huge privilege of walking with them and sometimes being the instruments to help them to rise up from the depths and smile again. But then, is it only palliative care that is supposed to do that? What is the purpose of healthcare? Let me share my screen to share some thoughts with you. What is the motive of medicine? What are we supposed to do? Are we here just to diagnose and treat diseases? Or is it a bit more than that? Trains are very efficient. I love being on trains. They are efficient in the sense, in the limited time that we have, they will get us to a certain destination. It may have beautiful names. This may be station health for all. That may be what it's called. We will have to get out here and attend to the healthcare that's possible in that locality. Efficient, but limited in its reach. Whereas, actually, to get healthcare for all, we may sometimes have to travel difficult terrain. Eric has done that when he visited us. He walked with us through the countryside, visiting patients. You will have to brave these places where there is hardly any path, sometimes striking new paths, because on the other side, there is somebody, and that belongs to 84% of global population, who are hidden there without access to quality healthcare, not only palliative care. The Astana Declaration of 2018, where world nations got together at the capital of Kazakhstan and came out with the Astana Declaration, says that health for all can only be health with all. If we leave out the person on the other side of this forest, how can we call it health for all? And they cannot get to us. We have to reach them where they are. That sounds frightening, does it? Have we got used too much to our air-conditioned, comfortable offices within healthcare palaces? Well, that's great. We can be great scientists, but 84% of the population will be left out. Oh, of course, you can always pretend that you have not seen them. Close the eyes and continue to work at the 15% of the population. That's one choice. But if you choose to see this man and his family, he is one of 51 million in low and middle income countries in serious health-related suffering. Of the 61 million people estimated to be in serious illness-related suffering, just from 20 disease conditions, more than 51 belong to low and middle income countries. And friends from India, weep with me, 7 to 10 million are in India without access to significant relief from suffering. And these are two of them. Let me tell you their story. When I saw them first, she was 40 and the son was 12. What was happening that day in Trivandrum was celebration of the World Palliative Care Day. I was there for the valedictory function as the minister and VIP stroked out, and as I was leaving, this 12-year-old boy came and tugged at my sleeve. He said, "Mom is calling you." His mom had sent the boy across to seek help from anyone who would listen. The people walking in front were big people and possibly too intimidating, and he chose to tug at my sleeve. I walked across to where the woman was sitting, and then it was obvious to me why she did not come to me. Her whole one leg from the thigh downwards was swathed in an ugly bandage, and she was blind. She was a single mother abandoned by her husband. She had been a diabetic since the age of 3, and gradually her juvenile diabetes progressed. And for the last 4 years, she had been blind. Anyone listening? If you visit Trivandrum, just let me know. I can take you out to meet them and talk to them. She had a diabetic foot which had spread so badly that the surgeon said it cannot be salvaged. She would need an above knee amputation. Of course, she was in pain also. Significant pain, both nociceptive and neuropathic. That is the place where she was living. She had no home of her own. Rather, greedy relatives had deprived her of everything. She had no home and she was living in this shack, which actually did not belong to her, with a mud floor. She told me about a weekend where they had to starve, no food. And on Sunday morning, the son said, "Mom, let us kill ourselves. I cannot bear this hunger anymore." And the mom said, "Son, hang on. Wait for another day. Today is Sunday. Mom will find some way." And somehow they got across to the healthcare center. And luckily, they found a very humane doctor there who put them up there. For the 3 months before I saw them, they had a home in the health center. And every day, the lowliest employee of the hospital, a hospital sweeper, every morning would bring them food which they would eat for all 3 meals, the mom and the child. Those people are there. People with compassion are all around us. They generally do not have an opportunity to do what their hearts ask them to. She did not know where she could go for support. Who would tell them about the government programs? A kind nurse told her, palliative care day celebrations are happening there. Go there and talk to people. Somebody will help you. But ladies and gentlemen, we have a problem here. I'm a palliative care person. Ours is a palliative care organization. Does she qualify for palliative care? Diabetes, blindness. The World Health Organization has defined it this way. Oh, 1 mile long. But it's for people with life-threatening illness. Does diabetes qualify? Does blindness qualify? More than everything else, does hunger qualify? Friends, we have to decide what's palliative care. This definition is 21 years old. Will you keep discarding people to no care because you do not classify them as life-threatening? I'll ask you, what is life to you? Is it just a beating heart? Is existence in hunger in this shack, life? Isn't life a little more than just bare existence with a beating heart? Something that gives you some enjoyment, some contribution to the rest of the world, some receiving, giving love, receiving love. Well, if we spend time on defining what life is, people will get rejected. But neither diabetes nor blindness may seem life-threatening. That is when you put on your high-income country lens and discuss it in academic rooms. And we, in 84% of the world, that's the low and middle-income countries, just take the definitions and guidelines from you and apply it, sometimes blinded. If we take the blinders off, and if we fight the feeling of helplessness that we have, then we will see them as human beings that are suffering. Because after all, the definition does say that palliative care is for the prevention and relief of suffering. I would call this a neo-colonization. Eric, before the session, we were talking about guidelines. You have worked in the WHO for a couple of years. Even now you are associated. I am talking about the problems in 85% of the globe. Definitions and guidelines are based on whatever is documented from the high-income countries, 15% of the world. And that kind of definition will handcuff us. And sometimes we have to break those shackles off and do what our hearts tell us to. Talking about guidelines and plans, whatever we decide, every single guideline that is brought out by World Health Organization is evidence-based. Certainly not irresponsibly done, very responsibly done, based on available evidence. And where does that evidence come from, friends? Where does the evidence come from? 15% of the population in Euro-American countries come out with 93.5% of scientific publications in this field. And we, in 85% of the world, provide only 6.5% of the evidence for all practical purposes. That means definitions, procedures, guidelines, all defined by the 93.5% of publications from 15% of the population are applied blindly by us. I'm sure I'm not exaggerating. And when we follow that definition and guideline, we will have to tell that blind woman and the child, sorry, this is not the place for you. Go back to your healthcare center and be fed by that sweeper till you die. What's the duty of the healthcare provider? In our country, it is not defined by law. In India, I don't know about other low and middle income countries. I suspect that the majority may not have. But a statutory body of the government of India, the Indian Council of Medical Research, has its bioethics department, define the duty of the healthcare provider as to mitigate suffering, to cure sometimes, to relieve often, and to comfort always. And the ICMR emphasizes there exists no exception to this rule. The definition will lie in an obscure corner of every institution's library, and our practices will continue as written in the textbooks created based on evidence from 15% of the global population. There exists no exception to this rule that the duty of the healthcare provider is to mitigate suffering. If the majority of healthcare providers do not accept that responsibility or do not know how to mitigate suffering, I am sure we in palliative care will have to show the way. We do. We try our best. We try our best to reach this woman and the majority of them. That is a 50.5 million people in low and middle income countries, to reach them where they are when they need it and relieve their suffering. But the biggest problem often is pain, like this woman. She was in agonizing pain. She said it felt as if somebody was trying to crack her bone with an axe. Do you see this interesting map of the world created by the Lancet Commission, of which Eric and I were also members? The Lancet Commission report of 2017 depicted access to opioids for pain relief. For all practical purposes, access to pain relief based to be depicted in this map of the world. See the morbid obesity of USA, Canada, and Australia. That would be the other side of the balance. That is, so much of opioid medications are there so that people die of opioid overdose. And on the other hand, can you see India? Oh my God, marasmic. Very emaciated. And most countries in our region continue to have this kind of malnutrition. We do not want to be here with this kind of morbid obesity. We do not want to be in this kind of marasmus, like the whole of African continent, almost whole of South America, and most of East Asia. Instead, our model could well be the Western Europe. The Western European countries, as far as access to pain relief and access to opioids are concerned, have arrived at a balance. Having the opioids available for pain relief, at the same time, using the right amount of restrictions to make sure that people who need it have access to it, and at the same time, the inappropriate and non-medical use are curtailed. They have shown that it can be done. That's happening for the last 50 years. And if you say it's only in Europe that can happen, I'm sorry, I disagree. Come to a tiny part of India here in Kerala, where access to opioids is 16 times more than the national average. Or why? Go to the low-income country, Uganda, where access is 3 times better than in Kerala. Now, this can be achieved. It doesn't take rocket science. Maybe that's the problem. It's too simple. And because it's simple, because it does not need expensive equipment, it is not attractive to the healthcare industry, which is running the healthcare in the world. This vulgar disparity in life around us is one thing to be addressed, certainly. But this, if I call it an error of omission of the healthcare system, we are not doing what we should be doing. Okay. But here is something worse. We are not only not doing our job, we are destroying people with healthcare by catastrophic health expenditure. The destruction is worst in the areas shown in bright red, including India and most of Eastern Europe and many countries in South America, most countries in South America. In India, the situation is among the worst 12 countries in the world. Here, 55 million Indians, more than 4% of the population, are driven below poverty line by health expenditure. 38 million of them only with cost of medicines. What should we do? Pretend not to see it? Say that it's not my responsibility and walk away? Well, a lot of us, at least palliative care, and a lot of compassionate doctors, nurses, and other healthcare professionals all over the country are refusing to look the other way. We are trying to do what we can. We know we are fighting against huge forces. We do not have the strength to take them on. But being silent is not an option. One more way, and then we'll talk to the solutions, I promise. One more way in which healthcare system causes suffering is with inappropriate end-of-life care. Here I give the link to the 2021 Lancet Commission report, 22, Lancet Commission report on the value of death. Does death have a value? At least get the report and read the summary. Let me share with you the painful experience that I was a witness to one of my medical professors who taught me. She had dementia. She was not swallowing enough. So, despite the advice of palliative care physicians, the medical scientists recommended, and she was given an nasogastric intubation, which she would pull out, of course. So they tied her up. Physical restraint increases chance of agitation 44 times. She became agitated. The physical restraint was made tighter, and she started responding with violence. But that only caused more reinforcement of the restraint. Eventually, she was intubated and ventilated. And the family had to walk in every morning and every evening for 5 minutes each and watch her. As a friend of mine described, Sindhu, I think Sindhu is attending the meeting. She described about her dad's treatment in a similar fashion, that every moment I saw him dying 1,000 deaths. The daughter of my teacher lamented. This was a person who gave a lot of love to others. He did not deserve to die this way. I'm sorry. I deliberately tried to change the gender to avoid somebody identifying the person, but then I am not a good enough liar and I gave myself away. Who gave a lot of love to others. He did not deserve to die this way. That daughter is even now receiving psychiatric treatment. This is what we are doing to hapless humans because we are not able to accept that death is the inevitable consequence of life. And because good-hearted, kind doctors have often the mistaken belief that they have a duty to prolong life at all costs, life being defined by them as a beating heart and nothing else. I would not wish this on the worst enemies. Choosing wisely India is created by the National Cancer Grid, a brilliant conglomerate of more than 300 cancer institutions in the country, and together they have brought out this set of guidelines. And one of the 10 low value or harmful practices that should be avoided in cancer care says, do not treat patients with advanced metastatic cancer in intensive care unit unless there is an acutely reversible event. But including those 300 hospitals, we all know what's happening every day. Patients with advanced cancer, if they have any money in the pocket, still die 1,000 deaths every hour in the ICU. And this is not international practice. That's the interesting part. Friends from low and middle income countries who are listening, please see this. Now, here I have two papers, one published in JAMA in 2019, which shows data from European intensive care units, which show that almost 90% of all patients in advanced illness in intensive care units, once treatment is considered futile, are taken off life support systems and offered palliative care instead, 90%. Whereas in our country with limited resources, see what's happening. Dr. Mani and others published this paper in 2021 from many hospitals, and the data show that instead of the 90% being taken off, here only 30% are taken off life support systems, even when treatment is futile. And they are taken off without palliative care. And 70% of them die in the intensive care units, even when you know treatment is futile, with the death stretched out over weeks or months. Nobody is even trying to justify the practice. This is the reality. Well, ladies and gentlemen, we in palliative care in this country are refusing to be handcuffed by a definition and a certain definition of life. For us, any serious illness-related suffering, not only the pain and other symptoms, any suffering is our duty. I know we cannot do everything. That's okay, that's acceptable. But not trying is not acceptable. If somebody says diabetes, blindness, not life-threatening, you can't treat her, I will refuse to obey. my colleagues will not stand for that. If we have to refuse this hapless woman and the boy, then our being healthcare providers becomes a joke, a cruel joke. What am I saying? I am saying that not only in low-income countries, but also in high-income countries, palliative care has to address any serious illness-related suffering, because it seems that there is not a lot of other streams that look after suffering. How did we take care of this problem? Oh, treating the pain and symptoms was easy. The doctoring that was done by a few of us, but that was not enough. It was on social media post saying there is a family without identifying the person. This is a story. They need help. Help us. Help did come. With the money that was given, we got a paid caregiver to be with her in the ophthalmic hospital, where she underwent retinal surgery. And she saw her son after 4 years. We got her treated by an diabetologist and podiatrist. She walks now. True, she needs a walker. True, she needs some support. But she has the hand held by the boy. And that boy, like about 300 other children in our unit, children of patients and patients' families, have their education supported. The money doesn't go from my pocket or any doctor's pocket. The money comes from the community. They are generous with it. And the person working outside India has offered a monthly allowance so that she could now, with the son, live in a rented home. But I want you to think, are we crazy people going outside the realm of healthcare? Is all this part of healthcare? I don't mean the podiatrist. I mean a social media post, fundraising, funding it, finding them a home to live in, educating the child. Is that the duty of the healthcare provider? If you have a doubt, look at the World Health Organization definition of health. Complete physical, social, and mental well-being, and not merely the absence of disease or infirmity. Physical, social, and mental well-being, not merely the absence of disease or infirmity, and that's health. Would you still question this, whether all this is the duty of the healthcare provider? Oh, if you want to run away from this, you can say complete well-being is not achievable. Therefore, the whole thing, you can wash off the whole thing and quickly walk away in the other direction. Or you can choose to think about it and do what we can. But when we do that in countries like ours, or in some low-income countries where healthcare is even harder to access, there will be this huge gap. In the first panel, my young friend Nitya has created this image where she says, up to this point, is the primary care system available in a Western European country? And there may be pain and other suffering, psychosocial suffering also, that is not easily treated in primary care. And that's the job of palliative care. But what would we find in India, or even less in some countries? The primary care access is limited. So much so, the unmet need is much wider. You can escape to the official definition and look after only this bit, or you can choose to see the suffering and try to address the gap. No, that's not the ultimate solution. Ultimate solution, I agree, is for primary care to improve. Let it improve. Let us work towards it. But in the meantime, will you abandon that woman and child and millions, 7 to 10 million others in India, and 50.5 million people in low and middle income countries to no access to any relief from suffering? Can you do all that? Come and see, we are doing it. Oh, we are not doing it with the perfection that you may achieve in a high-income country, but we are doing our best. We are not running away. Now, just a few do-gooders doing it in one corner of the country is just not enough. Very obviously, we accept the responsibility for advocacy. It is in the 14th century that the great Greek physician Paracelsus said, physicians are the natural attorneys of the poor. We rewrite this. Not only physicians, healthcare providers are the natural attorneys for the poor. And a quarter of century of advocacy by palliative care people in this country, in India, has resulted in the creation of a national program for palliative care. It took 19 years, but finally, the Indian Parliament amended the law governing opioids so that accessing opioids is now easier, provided healthcare professionals will want to make use of it. And then that is also now facilitated because the National Health Policy of 2017 in India includes palliative care. I know I am talking about only India because I know the problems are there in other low and middle income countries, but I am not sure about the nature of the problems. I am quite conscious that sometimes it can be much worse than in India. But India, after all, is 1/6 of the global population or more. And what we see here could be relevant to a lot of low and middle income countries. So the National Health Policy includes palliative care in the primary care. And thankfully, very recently, 4 years back and 2 years back, the undergraduate medical and nursing curricula now have included palliative care. And these did not happen spontaneously. These happen because of patient, sustained advocacy, not by taking swords and fighting the system, but finding the gaps, entering through those gaps, and calm advocacy, despite sometimes having to swallow insults. But this is the way that the low and middle income countries can improve, we strongly feel. And I'm so grateful that a lot of people like Dr. Jan Stensward and Sandro Pamplona, whom I quoted earlier, or like Dr. Eric Cracker, and so many people try their best not to run away, but to face the problem that is there in front of our eyes globally and do something about it. And this means we have to engage the community. I told you that woman got her treatment done and has a home to live in because of support from the community. The problem is we don't allow the community to come in. We have to open the healthcare doors, allow them to come in. And this means creating awareness, training volunteers, setting ground rules and core values, frightfully important. And then only engaging volunteers in care delivery. This is what we do. Come and see. We'll show you how our volunteers contribute to healthcare. It means not only doing all this, but periodic review. What do they get, the volunteers? Only the satisfaction. They should get the appreciation. And where necessary, course correction cannot be ignored. I have given the link to a WHO document, which is a guide for program managers a lot of useful tips there, though some of the things we have to learn on the ground. And that participation in the community has to be the foundation of effective care. If people, as I showed in the picture, not the train, the healthcare train will stop only at air-conditioned institutions. If people in those forests, in those small lanes, by the side of those small lanes are to get care, the community needs to be involved. But then not only that, palliative care is not only to be done by a few palliative care professionals, but it is something to be integrated into all healthcare. Again, as the World Health Assembly in 2017, 2014, World Health Assembly 67 advocated palliative care has to be integrated into the whole healthcare system. Every doctor and every nurse will look at suffering as they treat diseases. And eventually, that will result in true health, physical, social, and mental well-being. This, thank you, Khadi. I have come to close to the last slide. This happened at a World Palliative Care event, Palliative Care Day event in our city, in Trivandrum. About 40 people on wheelchairs were brought to the seaside. It took 160 people, 4 to each people on wheelchair, shifted from their home, often physically carried to a road and brought in a vehicle. And what did it achieve? I have told this story to some of you, certainly to you, Eric. This lady in green and red, see her? She is paraplegic. She does not have normal sensation in her feet, but she said, the waves touching my feet was the best experience that I have had in my whole life. Doctors and nurses did not do that. 160 engineering college students came and did that. And if health officially defined by WHO is physical, social, and mental well-being, is this not true healthcare? Of course, with the involvement of the professionals for symptom control and treatment of diseases. And I leave you with this final question. Is all this relevant only for low-income countries or low-middle-income countries? Would there be any relevance for high-income countries? When I visit your country, I look at the beautiful hospices. I walk through its corridors. I see dozens of lonely people in their beds. True, they press a button and a nurse would come running, and their needs will be taken care of. But most of the day, they are all alone. If they are well enough, they will roll their wheelchair to the window and keep looking out. And I know that outside on the street, in those cottages outside the hospice, there will be lonely people looking into the road from the other side. Why can't they get together? Loneliness is possibly, Eric, I know you will need people like you only can create the evidence to demonstrate to the world. I wouldn't even know. I wouldn't know the kind of research needed to demonstrate that. How bad is the disease of loneliness globally? And without community participation, can that be treated? Thank you, ladies and gentlemen. Thank you for listening to me patiently. I'll stand by to answer any question. And all easy questions I'll answer. Eric, please stand by to take the difficult questions.
Thank you so much, Dr. Raj. And yeah, it's hard to speak after you. I'm always so moved. But I also have a big apology because I think at our first lecture of the Global Palliative Care Lecture Series, I failed to properly introduce you when there was some difficulty with audio. So for those who don't know Dr. Raj, I'll better late than never introduce him. He trained in anesthesiology at the All India Institute of Medical Sciences in Delhi, the most prestigious training center in medicine in India. But noticed that suffering wasn't being adequately treated by anesthesia or anyone else, and essentially invented for himself palliative care. In his native Kerala, he founded the Institute of Palliative Care and created a network that he's alluded to of community-based palliative care services. He was able to tap into the community spirit in villages throughout Kerala, the state of Kerala in Southwest India, to get the communities to rally to create palliative care services, and also lobby the government of Kerala to provide a nurse for any community that organized in that way. He also successfully, those success stories that he showed, largely because of his advocacy, and Raj, you might not say that you acted militantly, but you also successfully sued the government of India for failing to provide pain relief. And the result of that was some of those governmental decrees that pain relief should be made accessible to everyone. And then more recently, you founded Pallium India in Trivandrum that continues to expand access to palliative care. Raj, you're a thought leader in global palliative care. And I think that in your example of the woman with diabetes, you also showed something that was very important, particularly to Paul Farmer, who was also our leader in so many ways, and with whom I discussed palliative care for many years. And I think that partly when he met you, I think he understood better that palliative care, as we see it, I think as you and I and many others who do this work in low-income settings, as we see it, cannot be the response to serious illness. It needs to be accompanied by efforts to improve disease prevention, early diagnosis, and treatment. And if we come across a patient who's suffering with a treatable condition, whether it's blindness or gangrene or lower extremity ulcers, diabetic ulcers, as you mentioned, part of our job in palliative care is to make sure that they get the treatment that they need, whether that's curative or not. So again, as you pointed out, palliative care needs to be contextualized, and the usual idea that we have in the rich, obese countries, as you mentioned, that we always know best and we have to provide the solutions for the rest of the world. This is a fallacy that I think is becoming better understood in palliative care, that it must be contextualized. And in our Harvard program, we're going to emphasize contextualization of palliative care, led by Dr. Hiba Osman. I want to get to questions, and there's some being raised, but I would just like to ask one question of you, Raj, if you would. When we work in different countries, we tend to explore, to look for the cultural values, traditions, and meanings related to serious illness and suffering and relief of suffering, and also end of life and afterlife. We didn't invent palliative care in the West. people have been caring for those who suffer and die forever. And those traditions can provide meaning and community and can generate accompaniment, which is often missing, as you point out, among those isolated in our rich countries. Could you describe some cultural values or traditions that make serious illness and end of life meaningful and turn what can be a very tragic experience into a more positive one in the culture or cultures of Kerala? Thank you. Over.
Thank you, Eric. Having worked in many more low and middle income countries than I shall try to answer the question less, but please supplement my answer with your experience. You ask about our cultural background and its impact in palliative care, healthcare as a whole. Of course, this is not only Indian culture or Kerala culture. This is human culture anywhere, which over a couple of generations has been, or in our case, by a couple of centuries of colonization, have been violated by civilization, modern civilization. We talk about autonomy as the guiding, overarching principle of medical ethics. But it's not the same in every place. What I have seen and read about in a Western high-income country culture is the supremacy of individual autonomy. Whereas what is indigenous to possibly to any culture at one time, certainly in our context, is collective autonomy. My own autonomy as an individual, if exercised beyond a certain limit, would invade on the autonomy of the child who cannot exercise it by himself, or the elder person in that home for the destitutes. We are citizens of one world. It's a collective autonomy, not individual autonomy. That difference in cultural value would be the most pronounced. And why speak of India? A visiting nurse from New Zealand taught us the translation of the last two lines of the New Zealand Maori song, which ends, what is the most important thing in the world? It is the people, the people, the people. Not the machines, not the air-conditioned palace. It is the people. And those people are kept out with armed guards, and we don't allow them in. Eric, I don't know if you know the neurologist Dr. Dhruv Gursahani, who works in Hinduja Hospital in Mumbai, and he says our corporate hospitals are fortresses that the poor cannot get into and the rich cannot get out of. We have built those fortresses and kept the people out. The single one point that's of cultural relevance that I'll mention is the principle of collective autonomy and the community being partner in healthcare, or as the Astana Declaration said, with control over healthcare. And when you came to Trivandrum, you saw that actually happening with the volunteers' participation. Oh, there will be many other cultural barrier things, including the acceptance of death as the consequence of life, as against the modern civilization fighting death as an enemy. many things like that. But your words of wisdom, Eric, please.
Thanks so much, Dr. Raj. But and I know we've gone over time, but if you don't mind, we have quite a lot of questions. Dr. Khan, would you be able to moderate some questions?
Yeah, and Eric and Raj, please take your time.
Oh, thank you.
Wonderful, because we have a lively discussion here. And thank you again, Dr. Raj, for this inspiring talk. And the last part of your talk actually answered the question I had, which was how do we make the community the center? How do we put the community at the center of what we do and harness the wisdom, the knowledge that already exists in the communities that we work in to actually propel PalCare? So thank you for addressing that. There's one comment from Biswas, which actually poses a dilemma that we can turn into a question. You mentioned, for example, all of the international guidelines that are created by people from high-income countries, and then to be applied to a different context in low and middle-income countries. For the guidelines to be really contextualized and appropriate, it would be ideal if they came from those who are going to be applying them, meaning guidelines for LMICs from people from that area. But we also know that those clinicians are burdened by just challenges in terms of how do you find human resources, time, funding, the opportunity to go get training and research. How do we resolve that dilemma of providing these people with the support they need to actually develop the guidelines that are relevant for the communities in which they work?
Kali, Dr. Biswas, thank you for the question. Very valid. We all live with that dilemma. Whatever resources we have, money, time, we spend on the immediate need of patients before us. So who has the time for research? Who has the money for research? I think we can have a win-win situation where the participation of the high-income countries come in and so long as it is not trying out the latest fancy drug which can destroy a few more human beings, but implementation research. Do we actually know what our people suffer from? What are the elements of their suffering? Who has documented the pain of that person with advanced cancer who is sitting up with an umbrella because his roof is leaking? So much of opportunity for research by collaboration. Eric, Biswas, Dr. Arnab Biswas, I think the East-West collaboration will work best here. And this is so important. We need to demonstrate the problem and the solutions.
I agree. Thank you. I think this would be opportunities for all of us collaborating around the globe to sort of figure out how to do this. This would be the way forward. This is a little bit similar, but naming the other dilemma around sort of integrating palliative care in primary care. So Dr. Punita Vati is asking specifically about how to entice or encourage the integration of palliative care services in the private health sector in India, for example, because when we know that palliative care is very human labor intensive.
Punita, I think Punita cannot speak. I think I would have asked her to answer her own question. This is a difficult one. So, Eric, I don't know if you know this. More than 65% of healthcare in India is on the private sector, which explains the destruction by catastrophic health expenditure also. So it's a question of making palliative care not only cost-effective, but also sexy enough for the corporate industry. Punita, I don't know the answer, but this I totally agree is something to be done. Dr. Nandini Vallat, whom you may know, who is now in St. John's, had done a study in NCG hospital in Bengaluru, where she, over a 2-year period of time, did some successful integration of palliative care. Even the term had to be adapted to supportive care, but she did it. So experiments have been done. I wish I had an answer, Punita, but I don't. But you will have to create that answer.
Wonderful, thank you. There are lots of questions here. The next one from Dr. Abebe, who's a palliative care clinician in Ethiopia, whom I had the privilege of meeting at AHPM when he was presenting the palliative care organization he just founded. His question is, what do you think is the way forward to narrow the global equity gap in care, education, and opioid access?
Interestingly, with that question, he has practically drawn a triangle. The care, including the policy, the education, and the opioid access. Dr. Nathaniel, you are in Ethiopia and in sub-Saharan Africa, in so many countries, that initiative of Dr. Anne Merriman in 1993 of making low-cost morphine available, empowering nurses to treat pain, including the use of oral opioids. This has done wonders, I understand, so much so up to 40% coverage of a country has happened, and it has spread to other countries in the sub-Saharan Africa. So the elements are adequate education of nursing population in countries where the doctors are hard to come by, and empowering them, and they reach out into the community and deliver the care. So the African example is something that I believe we all should learn from.
Wonderful. Dr. Saravan brings up a good point, which is that research often drives the evidence and policy making. What are all the global health efforts in the space of palliative care research and perspectives in low middle income countries? Feel free, Eric, to chime in as well.
Yeah, maybe Eric will be so much better at answering the question. I am one of the things asking the question rather than answering that question. Eric?
Sure. It's actually very apropos of what was being discussed here in Geneva today. And this gets back to also, I think, the first question that was raised, and that is the hypothesis that palliative care, when it's integrated into health systems at all levels, as Dr. Raj described, including home care, especially home care, because most patients who need palliative care are in the home, in the community. And when that integration is done at all levels, there's evidence from high-income countries and some evidence from upper middle-income countries that costs for the healthcare system, for public healthcare systems, are reduced because patients are able to get the symptom control, the symptom relief in the community, often in their homes, and don't need to travel back to overcrowded, expensive, what did you call them? Refrigerated prisons of the expensive tertiary hospitals. This can save money for healthcare systems. It can also provide financial risk protection for families of patients. Now, it's clear that there are some startup costs that are necessary to implement these palliative care networks. It's been pointed out by some of the participants that healthcare workers in low and middle income countries are often overwhelmed with clinical duties, don't have time for research, don't have time for anything else besides taking care of the dozens and sometimes hundreds of patients in line waiting to be seen. So there may need to be additional staff added to take responsibility for or share responsibilities for palliative care. But over years, and of course there needs to be training, the essential package of palliative care medicines is very modest, and we costed that with the Lancet Commission. So over a few years, integration of palliative care, the hypothesis is that integration of palliative care into healthcare systems can pay for itself. But we need these data. This is a kind of extended cost effectiveness study. So implementation studies are very much needed. And today at WHO, which is chronically underfunded, and certain areas like tuberculosis and palliative care are particularly chronically underfunded. So there are some ways to do what's called operational research or implementation science research to generate these data without putting excessive demands on people whose work, on clinicians whose work is already excessively demanding. So I think that's part of an answer to a couple of those questions. Yeah.
Yeah. And Arnab Biswas, just on an aside, is making a comment, just reminding us of the necessity for universal access to healthcare, that unless people actually have insurance and access to healthcare, that they're going to be going through financial toxicity and waiting till the last minute to access healthcare. So even if palliative care service is integrated into that healthcare system. Dr. Bikash Anand from Nepal, welcome. Thank you for joining us. Is telling us that he is the only, he or she, I apologize, is the only registered palliative care physician in Nepal. And what suggestion do you have for them to make palliative care more effective?
Dr. Bikash.
First of all, thank you for joining us.
Yeah. Hello, Dr. Bikash. Bikash, I am surprised because I thought in the mid 2000s, there were several palliative care initiatives in Nepal. Dr. Bishnu Podel, I know, has done tremendous work in making opioids available. And there have been several others. So I don't know the process of registration, what's the process, mechanism of registration. But Dr. Bikash, I'm sorry that I do not know about Nepal. Eric, though Nepal is practically next door to India, you know more about Nepal than I, don't you? Haven't you been there often?
I was there once. I had the great privilege
once.
of mentoring Dr. Bishnu Podal. And you're talking about advocacy, Raj. Dr. Podal succeeded in convincing one of the pharmaceutical manufacturers in Nepal to manufacture oral and injectable morphine, and I believe make it available free of charge. This was one great step forward, but to make palliative care, your question is how to make it effective. Well, I think that I would call attention to the essential package of palliative care that was suggested by the Lancet Commission, which had representatives from all parts of the world and all economic categories, and it's very much focused on low and middle income countries. And there's one point that I feel always warrants repeating, and that is that training is fine, but if those who are trained are not able to practice what they learn, the effort is wasted. There need to be policies and regulations that make palliative care part of the job description of clinicians at all levels. And again, that's adding an extra task to already overburdened clinicians, which is why there may need to be some initial investment to hire more staff. but there has to be the policy and the regulations that enable people or require people to practice palliative care along with practicing primary healthcare, oncology, cardiology, neurology, whatever it is, diabetology, tuberculosis. So that has to be there. And sometimes the policies and regulations are there, but still it doesn't happen. Why? Because there's often a great fear of opioids. This is one. So that even though doctors are technically or legally allowed to prescribe morphine, for example, for outpatients, they don't do it unless they're sure their bosses would approve. And that approval is often not there, or even there's implicit disapproval. So there's a lot of factors that can that need to be addressed to make palliative care accessible and effective. Thanks.
If I may add something, Khadi,
Yes.
the answer to that question from Nepal is partly also in the comments given by Dr. Bhagyashree Barlinge. Dr. Bhagyashree Barlinge, I know, is a palliative care physician from Arizona in USA. And she, I totally agree with what she is saying. Very often our advocacy is only to the lawmakers and to fellow professionals. We are forgetting to go into the common people. They will be our greatest supporters. In Kerala, surely that was our big success. When we demonstrated something, healthcare being given with compassion, the people embraced us. And the public support helped us in getting it across into policy. Without that also, coverage will not happen. But this marriage between the public interest and political advocacy, together that works.
Yes, 100%. Actually love that comment and was going to get to it. And I think it also answers in part something Dr. Parth Sharma is asking, which is how do we convince the government that palliative care is important and needs focusing on? And I think you've answered a few of those questions. Are there any other concrete practical tips that Raj or Eric, you may have for people who want to do advocacy for national policies and for the government?
In one thing that I have found difference between the advocacy in high-income countries and in countries like ours, that there, with the system of governance and management and the processes happening there, if you create evidence and take a good document across to lawmakers, some people would listen. With the kind of pressure that the governance and management operates in India, evidence, nobody has time to look at the evidence. Here, Dr. Parth Sharma, whatever we have achieved in the government, mostly true, as Eric said, I did once go to Supreme Court, but that was useful. But the biggest success has been in finding individuals who either have a personal experience or they are just people who want to do something good. It's not only medical people who want to do something good. So finding people with lived experiences is indeed a great step to do.
Wonderful. I think in the interest of time, maybe we'll take one or two more questions. Parul Raina is asking, what was so exceptionally done in Western Europe that they have apt morphine availability? I'm assuming it means that they have adequate, appropriate morphine availability.
Hadi, is there somebody from Western European country attending this who can answer this more authoritatively? But Parul, I think the most important thing is concurrent education and the policy went together. The problem that happens, okay, in some high-income countries, especially after the turn of the century, is that the education in pain management did not happen. Say in USA, the idea was spread that, okay, opioids will not be addictive if used in pain. Just start giving this medicine that we manufacture 2 times a day to everybody in pain. Whereas in Western Europe, the inclusion of pain management and palliative care in undergraduate education and the hospice system and thereafter its growth into hospitals happen concurrently. But I'm certainly not an expert on that. But for our country also, I feel that should be the balance. Concurrent education of professionals as well as governmental advocacy, along with public advocacy.
Wonderful. I think that that is technically the last question. I just wanted to make one quick comment before I turn it over to Eric to take us home. So thank you so much again, Dr. Raj, for this wonderfully inspiring talk. I think it's always not only refreshing, it's mandatory that we are reminded why we are in this field in the first place. And it's not cliche, it's not Pollyannish. It really is at the core of why we do what we do. And a couple of things that I'll take away with me beyond a lot of the other things you mentioned is, again, centering the community. The community harnesses so much knowledge and wisdom, and there's so many resources that they have that we should kind of really partner with them and invite them to help us deliver appropriate palliative care. I think we've now talked about contextualizing palliative care many times, but it is mandatory that the care we're providing has to reflect the realities of the people who are not only providing the care, but receiving the care. And we can't do it without the ideas being generated from those people. And how do we support them to have the resources, the time to do that is probably where the question lies. And then how do we then make sure that the guidelines are reflecting those values? And one of the last thing that I remember you said is we may not do it perfectly, like the woman with diabetic foot who comes in and we're not thinking of her as our typical palliative care person. We may not be able to do it perfectly, but not trying is not okay. We have to try. And that is something I'm going to take away with me. Thank you so much once again for doing us the honor of starting our lecture series. And thank you to everybody who's joined us from around the world. Eric.
Thank you, Dr. Khan. I'll just add that, it struck me many years ago that what Paul taught us, what Paul meant by accompaniment was really something that Raj was, what Raj calls walking with the weary, and what he was practicing and advocating was very much parallel to what Paul Farmer was advocating as accompaniment. And so it was wonderful that you were able to meet. I believe in Ireland was the first time, as I recall, and I know that he was a great admirer of yours. I'll just close by referring back to what we were talking about at the beginning, palliative care, indeed all of medicine and nursing as a calling, a response. And this is something that I understood much better when you explained to me years ago, Raj, that the greeting of namaste means I greet the God in you. And I think no matter how abjectly poor and how emaciated and suffering or with wounds